Thank you. I don't like things in between. I'm a mover, as those of you know. I'm Dr. Lisa Owens. I am a general surgeon. I have been practicing at Grand Itasca for almost 6 years. I have a special interest in treating breast diseases, not just breast cancer, but benign breast diseases as well. I think that I've seen many of you on and off for different things. And the same thing I told you about the colon stuff, if you have something that's super complicated, I don't have a problem sending you someplace else. If you have something that we can do the exact same thing for you here as they would do in the cities or at the Mayo, then we'll do it here. And I think that that's a really strong thing to have in this community for people, because it's a long drive to Rochester when you feel like crap. Okay? Objectives, we're going to identify methods for diagnosing breast cancer. We're going to talk about strategies to treat breast cancer and understand ways to decrease breast cancer risk. Now, in the preventing breast cancer, we're not super good at that. But what we are much, much better at than we were 20 years ago is preventing death from breast cancer. Okay, so that's what our goal is. So breast cancer, globally, it's the most frequently diagnosed cancer and leading cause of cancer death in women. In the US, it's the most commonly diagnosed cancer and second most common cause of cancer death. And it's the leading cause of death in women aged 40 to 49, cancer death. 2011, 230,480 women were diagnosed with breast cancer. 39,000 died from breast cancer. So one thing that I tell all of my patients who have breast cancer is that most women who have breast cancer don't die from breast cancer. They die from something else. Okay, so that's always important to remember. Multidisciplinary approach is very important. People don't die from breast cancer if we have a lot of people taking care of them. Okay, so it's not just me, it's oncology, and it's infusion nurses, and it's social workers, and it's physical therapy, and all of us work together as a team to take care of a woman with breast cancer. So 1 in 8 women will have breast cancer. So if you have 10 friends, by the time you're 70, 2 of you at least will have had breast cancer. Okay? Most women with breast cancer don't die from breast cancer. And since the 1980s, the chance of dying from breast cancer has gone down 30%. Okay? A lot of that comes from screening, and that we're finding breast cancers early. In the 1980s, we had bad mammograms. We couldn't see good pictures of breasts. So most women who were diagnosed with breast cancer had a large breast tumor when they were diagnosed. So that's down. It's also a huge improvement in the way we treat breast cancer. We've had a lot of advances in the chemotherapy and targeted therapy for breast cancer once you have it, so that's good. So diagnosing breast cancer, how do we diagnose this? Physical exam, that's the good old-fashioned way. I feel a lump. The doctor felt a lump. Mammograms, first used in 1948, a long time ago. 1962, they started using the double squish method, for those of you who are here. Squish from side to side, squish from top to bottom. That gives us a better picture of the breast tissue. Okay? Ultrasound, used a lot more if you can feel a lump, or it's used to confirm things that they might find on a mammogram. It's used in women who have very dense breast tissue because mammograms don't show a lot of detail in those women. And then MRI. MRI is new, it's upcoming. The indications or the reasons why we do MRIs for women with breast cancer or suspected breast cancer, it's changing. There's not great evidence that it helps the way we thought it would, so it's very specific, the type of people who we ask to get an MRI. And anybody who's had an MRI in here, it's not a whole lot of fun. So, I mean, there's not people lining up to say, oh, please, let me get into that tiny little space that's very noisy and lie still for an hour. I just can't wait to do that. So we don't want to put people through things that they don't have to have. Exam findings, when you go to your doctor, when you're doing an exam yourself, things that we look for: lumps, skin changes, or nipple changes. So most of the time if somebody comes in and they say, you know, I feel a lump, we don't just go right to the operating room and take it out. We want to know more about it. Just because you feel it doesn't mean we know how big it is, doesn't know how deep it is, we don't know what it looks like. So we usually get a mammogram, an ultrasound, something. to help us have more information about that lump. Even if you had a normal mammogram 6 months ago, we'll get another mammogram, okay? So coordination is important between the primary care doctor, who might see somebody first for when they have a lump, between the surgeon, and between the radiologist, because we don't want to put you through things you don't need, and we want to do things quickly. So we have a system at Grand Itasca. If somebody has a lump, they see their primary care doctor, they go to radiology, they get the studies, then they might and usually do get a biopsy before they ever come meet with me. I get the job of telling the results of the biopsy. So that's a person that tells you it's face-to-face. I may or may not have met these patients before, but I think that it's very important to have a person face-to-face diagnosis, because in some cases, in the past, people might have gotten a phone call, hey, you know that mammogram? Yeah, you have breast cancer. Where are you? Who are you with? Are you alone? Are you driving? That's not a good situation. So I like to meet with patients eye to eye, so I can remind them most women with breast cancer don't die from breast cancer, okay? And then we talk about the rest of the stuff. So teamwork. If we want to succeed as a team, we need to put aside our own selfish individual interests and start doing things my way, okay? Any of you who may know me, that may or may not be something that I would maybe say. So different things that we find. Paget's disease of the nipple. Now this is a persistent, scaly ulceration of the nipple. The Paget's disease, or the nipple changes, are not necessarily a cancer, but they're very highly coordinated with a breast cancer underneath in that breast someplace. So we can biopsy that and they say it's Paget's disease, but there's not cancer there, but that means we really need to look closely at that breast because we're missing something, okay? This is an inflammatory breast cancer. That breast is very swollen. It has what we call peau d'orange changes, which means you can almost see the little pores because that breast is so swollen and it's red and it's hot. And this happens quickly. It's not something, oh, it's been like that for months. It's like my breast was pretty normal yesterday and now it's a little bit red, and by next week it has this huge, and many times it's thought of as an infection, but it's actually a breast cancer that's moving very quickly through the lymphatics of the skin. Mammograms. Screening. It's all crazy right now. So average risk women, age 40 to 50, discuss it with the provider, because there's some people who say that women age 40 to 50 are at a low risk of breast cancer, so they shouldn't be getting a mammogram every year or every other year. I'm not a believer in that. I think that women at 40 should start getting a mammogram, and they should get one every year, because seeing the tiny changes in mammograms are the things that let us find breast cancers early. But this is still an ongoing debate. Okay, 50 to 74, they say one every 2 years. Some people say one every 1 year. It depends on whether you're talking to the Breast Society, whether you're talking to the American Cancer Society, whether you're talking to the people who run the insurance companies, whether you're talking to people who run Medicare. Everybody has a little different opinion. So these are things that you really need to talk about with your provider and make sure that you're getting what you need. Don't let anybody tell you you don't need a mammogram, okay? 75 plus, they say, every 2 years, but if you got a lot of health problems, then maybe you don't. I've had many a patient in their 70s and 80s whose doctor told them, oh, my doctor told me I don't need mammograms anymore. No, because you're healthy. If you're going to be around until you're 80 or 90, we want to catch those breast cancers. I operate on women in their 80s and 90s for breast cancer frequently. Okay? Doesn't mean they're going to die from breast cancer, but we still need to get that cancer out of there. Okay? We don't want that to become a problem. So most abnormalities are not cancer. This is the argument against having a mammogram all the time. About 15% of breast cancers that we find are actually not visible on the mammogram. So that's another argument against mammograms being the only way of screening. Soft tissue mass or architectural distortion. So that means something looks funny. And that's very subjective. So we want to have somebody reading our mammograms who knows what they're doing, who sees mammograms all the time. You don't want somebody, oh yeah, that mammogram looks fine, and they've only looked at one in the last 3 years. You need somebody who does it all the time. And then microcalcifications are clusters of white dots. So in this lobule right there, that's benign. That's not a breast cancer. That's something called a fibroadenoma. But it's something that we would look at with an ultrasound to make sure it looks benign under the ultrasound as well. This is that spiculated mass. It's like a dense white grouping, and you can see that there's fingers kind of growing out of it. Very suspicious for a cancer. We can't say it's a cancer until we take a piece of it and put it under the microscope, but that's very suspicious. These are those white dots. Okay. Those are microcalcifications. When breast cells start to misbehave, they collect calcium, and the calcium shows up on a mammogram. Sometimes it's just old breast cells, but sometimes they're breast cells that are trying to become a cancer, so that's why we check for those too. This is a left breast and a right breast, and this is a cancer, and that 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 is a cancer. So that's a lot of changes. This is kind of a normal breast, and you see that there's a lot of darker gray tissue. The darker gray tissue is fatty tissue. As we age, the breast tissue is replaced by fatty tissue, and this is a good background for a mammogram. This makes it easy to see those things that are abnormal. This patient hadn't had a mammogram for 10 years. So it's important because something would have shown up before that, and we could have done a different treatment. Okay. This is a mammogram. Remember that inflammatory breast cancer where it was very swollen? This is what that looks like on a mammogram. This is a normal breast, a little bit of scattered white density, which is the breast tissue. This is a breast that's full of breast cancer. All that white is breast cancer. So they have categories. When you guys get your letters from the radiologist, sometimes it sounds funny, and I get a lot of very nervous people who call me and say, well, they said it's probably benign, but does that mean it's maybe cancer? And it's like, no, they have to put that terminology in the letters. It's mandated by the government. These are the terminologies they have to use. So category 0, they need more information. 1 is negative. 2 is benign. 3 is probably benign. 4 is suspicious. So 4A is a low suspicion, 4B is a moderate suspicion, 4C is a high suspicion. Category 5, that one that I showed you with the little fingers reaching out, that would have been a category 5 mammogram. That's highly suspicious. And category 6 is a mammogram on somebody who we know has a breast cancer, so they know that that's there. Don't freak out when you get the letters, they have to say that. This is kind of a flow, so we know we have a standard way of treating patients who have an abnormal mammogram. BI-RADS 1, BI-RADS 2, BI-RADS 3, BI-RADS 4, BI-RADS 5. And this is how things should work in most cases. It doesn't mean it works that way every time, but that's our goal. Our goal is to treat patients in a systematic fashion so we don't miss something. People don't have to wait, and they don't have a duplication of treatments, a duplication of studies, a duplication of other visits and services. Ultrasound, if we find something on a mammogram, we look at it with ultrasound to see, is it solid? Is it a cyst? Does it transmit? Does it look benign? It increases the sensitivity and specificity. And it's a much better way of looking at dense breast tissue in women under the age of 40, because mammograms show a lot of white, dense tissue, and the ultrasound can show us the differences in what that tissue looks like. So this is a very boring, this is actually an ultrasound of that first lobule that we saw in the mammograms. So it's boring. It has great margins. There's no shadowing. It's boring. That's a fibroadenoma, okay? Benign. This is a cyst, also boring. It actually has through transmission, so there's more signal behind this than there is in the tissue around it. Boring. Good borders. Boring. This is a cancer. So this is shadowed. There's something here. It doesn't have a good border. It's not distinct. And behind here, that ultrasound doesn't transmit through. So that tells us it's denser than the tissue around it. So when you shine a light, if it creates a shadow, there's something there. And so this is what a breast cancer looks like. This is an MRI of breasts. This is done in a screening, and this is someone who's a high-risk patient, which is one of the indications for doing a breast MRI. And the white is dense breast tissue, but there's a very distinct nodule in that breast, in that white dense breast tissue. It's tiny, but this is why we screen people who have high risks with MRI, because that wouldn't show up on a breast mammogram, it would not show up on a breast ultrasound. So this lets us find things that are very little and early. Biopsies, 30 years ago, 20 years ago, when I first started practicing, we didn't have a great way to do biopsies other than go to the operating room. So if somebody had an abnormal mammogram, we didn't have our fancy machine where we could stick a little needle in there and take a piece of it and know what was going on. We had to go to the operating room. We had to struggle to get a wire in preoperatively because we didn't have the special machines. And sometimes that woman would go to the operating room to have a breast biopsy and she would wake up with a mastectomy because it was a breast cancer and we didn't have another way to treat that. We've come a long, long way so that we help plan and we prepare. So we can do that with mammogram machines. We can take a biopsy. We can take a biopsy with an ultrasound machine. We can do a core biopsy if it's a palpable lesion. We can do an MRI guided biopsy if it's something we can only see by MRI. And we also can take a biopsy of the axilla. So if somebody has a breast cancer and we look at their armpit with an ultrasound and we see something that's suspicious for a node that has cancer in it, we can biopsy that. So we know a lot more going in so that we can plan to do the best thing for that patient. So this is an ultrasound guided, and they actually have gloves on. Sometimes they show pictures in here and it's like, oh my gosh, who drew that? Because the doctors would always be wearing gloves. So they can go in and they can take a needle and they can look at the ultrasound, they can make sure that the needle's in the right place, and they can take fluid, they can take a piece of tissue, so that we can put that under the microscope and look at it. This is actually a biopsy of a nodule. That's the needle right there going into that nodule. And we can see that happen real time. We know that we're getting a piece of what is the abnormality. And so most of the people will warn you, there's going to be a noise. It's a pop. Most of the time it's not real painful. The numbing medicine burns. But we have all the numbing medicine in the world. So if anybody ever wants to do a biopsy and it is not numb, you tell them to stop. I need more medicine. This is calcifications. And this is something that we would do a stereotactic guided biopsy. So they put a needle into those calcifications. They took two different pictures, and the computer can tell exactly where those calcifications are, exactly where to put the needle. The needle goes in and it sucks those calcifications out. Take the needle out, put the Band-Aid on, and then we have our tissue. They put a little marker in there too so I can find it if I need to. Biopsy findings determine the next step. So if it's a ductal carcinoma in situ, which is a stage 0 cancer, abnormal cells but they haven't gone anyplace, that helps us decide on what's one treatment. If it's invasive cancer, that leads us to other treatment options. Depends on the tumor size, what size the breast is, receptor status and HER2 status. So receptors for hormones, if those receptors are there, that helps guide our treatment. HER2 is a mutation that happens in some breast cancers. We have a very targeted chemotherapy for that, but it also means that that cancer is more aggressive, okay? Axillary status, so if you've got cancer already spread to your lymph nodes, we know from years of research on millions of women that that cancer, if it's already in the lymph nodes, women do better if we do chemotherapy first and then we do surgery. Less likely to die from breast cancer. It's kind of counterintuitive. Many women say, I want it out. I just want it out right now. I don't want to mess around. But we have to sit down, we have to back up, and we have to say, you have a better chance of being around 10 years from now if we do the chemotherapy first. Okay? And then patient characteristics and preferences. You're 86 years old. I'm not going to recommend that we do a mastectomy because that's a big surgery. It's a lot of recovery. If you absolutely told me I want a mastectomy, I would say, okay, but understand time in the hospital, it's time healing, it's difficult things going on. The chance of breast cancer killing you is very, very small for the risks that we take when we do a big surgery, so that patient characteristic. But if you're 40 and you have a large tumor and a relatively small breast, then mastectomy may be what the option would be to best treat that cancer. So individual preferences and characteristics are really becoming the way we manage breast cancer. So early stage breast cancer, advanced breast cancer. So important to know the difference, because early stage is best treated with surgery first. Later stage or locally advanced is best treated with chemotherapy first. And that helps to improve survival. Teamwork, the possibility of blaming the other. Certainly wouldn't be my fault. Treating breast cancer. So 2698 BC, the way of treating cancer was spiritual care, pharmacology, diet, acupuncture, and the treatment of the specific disease. Okay? It's very strange that we're coming around to these kind of holistic treatments again, paying a lot of attention to nutrition, paying a lot of attention to acupuncture, spiritual care. We know that people who have a good support system, whether it's through your church or your family or your neighbors, that taking care of the spirit, those patients do better. Okay, their immune system functions better, they have less pain, they have less cancer recurrence, they survive for a longer period of time than patients who are alone without good spiritual care. And treatment of the specific disease, that was like the last thing that they did back then. They changed everything else first. Mastectomy, 1844. Notice the doctors don't have gloves on in this picture because they didn't know the gloves helped. And they notice the patient is also awake when they did the mastectomy because they didn't have anesthesia. So breast cancer was not a very survivable disease in the 1844s. Mastectomy is still an option, but it's not the only option. So many patients have breast conservation therapy, which is a lumpectomy and radiation. We know that lumpectomy and radiation for many patients has the same exact survival as if you have a mastectomy. The risks of the surgery are far less. So survivally equivalent, cosmetically acceptable breast. Depending on where the tumor is, how big it is, it may not be the best cosmetic result. So then we would say, you know, we might as well do a mastectomy. And it has a low rate of local recurrence. So that's no age limitations. It can be invasive ductal or lobular cancer. It can be ductal carcinoma in situ. Tumor location can change it. Lymph node status, positive lymph nodes, it doesn't change whether you can have a lumpectomy or not. It doesn't change the surgical thing. They're still equivalent whether you do a mastectomy or a lumpectomy. So you can't have it if you have that multiple spots of cancer. If there's diffuse malignancy, if you've had radiation before to the breast, you can't do it again. Third trimester of pregnancy, which is actually a fairly significant problem treating pregnant women with breast cancer. Because we can't give a lot of chemotherapies because it harms the baby. We can't do a lot of surgery. We definitely can't do radiation. So that is a very, very specific, special kind of treatment. And then if we do a therapy and the margin says there's still cancer cells, we have to go back and take more, and there's still cancer cells, we have to say, you know what, let's stop doing the surgeries. Let's actually just take the breast off and stop that. Mastectomy, availability of radiation. Some people say, you know what, I can't get to Hibbing to go to radiation every day for 5 weeks. Well, then mastectomy would be one of the options we would talk about. We'd also talk about the options, well, maybe we don't need to do radiation. So that's the thing. Total mastectomy is a removal of all the breast tissue and the lymph node from the armpit. You can do a skin-sparing mastectomy where we take very little of the skin. That is something that we do when people are considering having a reconstructive surgery. We can even do a mastectomy where we actually leave the nipple in place. We usually do that for a non-invasive cancer. and a cancer that's far away from the nipple. Okay. Modified radical mastectomy, that is more traditional. That's all the breast tissue and all the lymph nodes from the axilla. Leads to women having that really big swollen arm that you may remember from, they wore a sleeve and hand swollen. When you take all those lymph nodes out, the risk of having that lymphedema in the arm is about 30%. So we don't do this. We don't usually have to do that surgery anymore. This is what a mastectomy looks like without any reconstruction. Reconstruction, we offer it to all patients. We can't do it here at Grand Itasca. If somebody wants reconstruction, I usually send them to Piper Breast Center. They have fabulous plastic surgeons that do a great reconstruction. I've also sent patients to the Mayo, who also have fabulous plastic surgeons who do great reconstructions. Many patients say they don't want to go through the hassle of that. It's a much bigger operation, more complication risk. But in the long term, it doesn't change survival. And it can be done at the time of the mastectomy, which is convenient to have a one-stop shop. You get the mastectomy, get the reconstruction started, have that all done at one time. It can be delayed as well. There's no burning of bridges. If you have the mastectomy and decide 10 years later you want to do reconstruction, that can still be done. Okay. This is a reconstruction done. It's a nice one. They don't put pictures in, you know, the surgical shows for somebody who has a bad reconstruction. And yes, they're fake. The real ones tried to kill me. It's one of my very favorite t-shirts. Chemotherapy. So chemotherapy is used to treat the possibility of cancer cells that have spread throughout the body. So I can do surgery and take out the lump, but if there's cancer cells elsewhere, we can't do surgery and take all of those out. So chemotherapy is toxins that go into the bloodstream, and they go to every cell that the blood goes to, including cancer cells, but also including healthy cells. So the balance of chemotherapy is to kill all the cancer cells without killing the person. Okay? It damages cells that are growing quickly. So it damages the hair-growing cells, the GI tract cells, the immune fighting cells, so the bone marrow cells. So people get low blood counts, tend to have more infections. They lose their hair, they have diarrhea and nausea, sometimes the mouth sores. Yes, but it gets better, okay? The chemotherapy wears off, okay? That's the only way we have to do it right now. But we're getting more and more focused. We're learning more about specific markers that go with cancer cells that we can focus on treating only the cancer cells and not hurting the rest of the cells. So that's what we're moving towards. How do we find out if there's cells that have gone other places? We do PET scans, I take out that lymph node from the armpit, we do MRIs, and then we send the cancer cells themselves off to have something called an oncotype test. That oncotype looks at 21 different mutations in that cancer. That's very specific. My cancer is different than anybody else's cancer, and that specific cancer that belongs to that patient fits into a profile, whether it's a low-risk cancer for spreading or a high-risk cancer for spreading, or an intermediate risk for spreading. And that helps us determine whether that patient's going to benefit from chemotherapy. So we're moving away from all stage 2 patients get chemotherapy, all stage 3 patients get chemotherapy. When we say stage 3, that encompasses millions of patients. And all of those patients are different, and all of those tumors are different. So what our future is with treating breast cancer is looking at that specific tumor and determining how best to treat that patient. Very individualized. Radiation treats the breast and the armpit sometimes to decrease the risk of recurrent breast cancer in that area. So that's how it works to decrease the chance that somebody's going to die from breast cancer. There are experimental protocols out there. Some people are having a very high dose radiation for only 3 days. There's radiation protocols for 5 days. There's 3-week protocols. They're all experimental, and we don't know if they're working. If something doesn't work, then the chance is that the breast cancer comes back. The other thing that can happen with high dose radiation is you can get skin burns and breakdown of any surgical sites. So those are kind of some things that we take into account when we decide if the specific patient is doing it. Hormone therapy. blocks estrogen receptors. Most breast cancers have little catcher's mitts on them. If estrogen lands in the catcher's mitt, it says, oh, I should grow, okay? So if we can block that estrogen from landing there, we can keep any cancer cells from growing. And so tamoxifen, Arimidex, there's a variety of different ways to block that estrogen. We know that taking those pills for 5 years decreases the risk of breast cancer coming back. And now they've moved on to looking at 10 years. And sometimes they change depending on the risk factors. They have some side effects, depends on if you're young, if you're old, what kind of bone density you have, if you have other cardiac issues. They don't make you sick. They don't make you lose your hair. They give you hot flashes and mood swings. It's like menopause all over again. Great, exactly. But they do decrease the risk, and it's a pill that you take. So you don't have to go get an infusion. It doesn't make you sick. So woman with breast cancer, here we go, let's go, do. Man with the flu, I'm gonna die, somebody help me. Risk factors for breast cancer. Now, some of these we can change, some of them we can't. Okay, female, 100 times more frequent for women to have breast cancer than men to have breast cancer, but men do get breast cancer. And when men get breast cancer, it's very important to look at the genetics, because most men with breast cancer have a genetic mutation that leads to breast cancer. It's a BRCA mutation, a breast cancer gene. Obesity increases the risk for breast cancer. Tall stature, we talked about this. If you're more than 5'9", increased risk of breast cancer as a woman. Now, and this kind of leads us into why. And I think that it probably has to do with exposures to growth hormones, whether they're the growth hormones that you make as an adolescent when you're growing, or whether they're growth hormones that are in the environment as an adolescent when you're growing. So they think that that's more of an exposure risk. The thing that makes you grow taller is also the thing that makes your breast cancer risk go up. Okay? And that would be maybe an endogenous estrogen level. Women and men all have estrogen. Now our levels are all different. Our body regulates that. That's what we do. One of the reasons that obesity increases your risk is because the peripheral fat cells increase the amount of estrogen you have. Okay? So that increases your endogenous estrogen level if you're overweight. Dense breast tissue makes it harder to find breast cancer, but it turns out that it's not just harder to find. If there's a 25% difference between your breast cancer and the average person of your age's breast cancer, that increases the breast cancer risk. We don't know why. Okay? Early menarche, late menopause, more years of cyclical hormone exposure. You can't change that. I mean, nobody can go say, hey, I really don't want to start my period till I'm 17, and I'd like to have menopause when I'm 36. Can't do it. Nulliparity, okay, no babies. If you have no babies, your breast cancer risk is increased because you have increased risk of cyclical hormone exposure, because those babies interrupt that period for 9+ months. And then if you breastfeed, that interrupts it for longer. Breastfeeding reduces the risk of breast cancer. Okay? And increased age at first pregnancy. After 30 increases your breast cancer risk. But you can't go back if you're 32 and try to get pregnant when you were 28. So we can't really, So breast cancer history, personal history increases your risk. Family history, but not like a family history of my cousin's mom's sister had breast cancer. It's a first-degree relative. So first-degree relatives, moms, dads, brothers, sisters, kids. Okay? 2 times the risk, doubles it. 2 first-degree relatives, 3 times the risk. Okay? So those are the people that we really need to consider doing things like MRI, increased screening, increased treatments. Higher risk patients, they've had a biopsy that showed atypical hyperplasia. Means they're not cancer cells, but there's abnormal cells on a biopsy. increased risk for breast cancer, more than 20%. So more than 1 in 5 chance of having a breast cancer if you have that. If you have lobular carcinoma in situ, LCIS, increased risk of breast cancer. Now the thing that's not super intuitive about that, if you have a biopsy and you have this in the right breast, your breast cancer risk is increased both breasts. It's not that that LCIS is going to turn into the breast cancer, but it says that you're at high risk. And the DCIS, more likely to be breast cancer in that same area. So ductal carcinoma in situ. BRCA positive. So the 2 first genes that were identified that were associated with an increased risk of breast cancer were called BRCA1 and BRCA2. Now there's about 15. We don't know exactly what their relationship is, but the more genetic abnormalities somebody has, the more likely they are to get a breast cancer. Increased screening for these people. So sometimes we say we want to screen with an MRI and a mammogram every year, 6 months apart. So in January you get your MRI, in June you get your mammogram. If you're under the age of 50, you also get a full breast ultrasound both sides. Now that sounds like a lot, okay? But we find small tumors that way. And the hormone blockers, we know that giving tamoxifen or one of the other estrogen blockers to people who have atypical lobular hyperplasia and LCIS and BRCA positive if they're the type 2 BRCA, we know that those hormone blockers decrease their risk of getting a breast cancer. So many patients that I see that have these atypical hyperplasia, LCIS, DCIS, end up getting sent to the cancer doctor because we're a team, and we talk about how we're going to treat them and how we're going to screen them to help prevent them from getting an advanced breast cancer that might kill them. Okay. Alcohol is dose dependent. Okay. So that means that if you drink 1 glass of wine a day, your increased risk of breast cancer isn't very big. If you drink more than 5 alcoholic beverages a day, you're up in that 1 in 5 chance of breast cancer. Okay, so you increase it over the 20% and make it at a high risk situation. Smoking increases the risk of breast cancer. Night shift work, really? And probably has to do with hormone regulation because your sleep cycle is off. Okay, that's what they think. Radiation exposure, so they used to do radiation to the chest for acne back in the day, increased risk of breast cancer. Women who work in the radiology department who don't wear their little protective vest, increased risk of breast cancer. Okay. If you lived in Chernobyl, increased risk of breast cancer. Okay. So protective factors, we talked about breastfeeding. You can't go back and change that now, I'm sorry. Physical activity, we know that 30 minutes of exercise a day. It doesn't have to be running a marathon, it can be yoga, it can be swimming, it can be biking, it can be walking. 30 minutes of exercise a day is better than any chemotherapy we have at preventing a recurrence of breast cancer. Okay? It also is better at preventing recurrence of colon cancer, it's better at preventing Alzheimer's. 30 minutes of exercise a day is probably the easiest thing we can do to decrease the risk of cancer in this country. But I don't know about you guys. This morning I got up, I was planning on doing 30 minutes of yoga, and the server was down. So I might as well go home and have a glass of wine after this. I don't know.
Might as well.
Okay, Mediterranean diet, plant-based, fish and olive oil, shown to decrease the risk of breast cancer. Soy and plant estrogens, kind of plus minus on that. It depends on the culture. If you live in Japan or Korea, soy protects you from breast cancer. If you live in the United States, we're not really seeing that. So that's kind of a plus minus. If you want to go to Japan and eat tofu and edamame, please do. But we don't know that it protects us here. And then fruits and vegetables. Again, a lot of cancer preventing chemicals that we find in fruits and vegetables that we don't know exactly how they're related, but women who have a diet higher in fruits and vegetables have a lower risk of having breast cancer. And I like to say I have a plant-based diet, except for when I want bacon. And that's what makes it so hard. Because when we look at all of these things, you know, it's like, okay, do you exercise 30 minutes a day? Yes, 4 to 5 times a week. Okay, except for when I don't. Do you eat a plant-based diet? Yes, except for when I don't. And so it's very hard to funnel this down and focus on exactly what things are changing that breast cancer risk. But we do know for sure that the 30 minutes of exercise a day does, and breastfeeding. So conclusion, 1 in 8 women will be diagnosed with breast cancer in their lifetime. Most women with breast cancer don't die from breast cancer. Most breast cancers occur, 80% of breast cancers occur in women without a family history of breast cancer. Okay? So when I see people and they say, I don't want to get my mammogram, nobody in my family has had breast cancer, I'm like, you are the person who's going to have it then. If nobody else has had it, it's you. Get your mammogram. Discuss the screening mammograms, ultrasound, MRI with your doctor. Individual strategies, depending on your history, your physical stuff, your medical stuff that's going on, what your insurance will pay for, what we can get you if it won't pay. Eat healthy, stay active to decrease the risk of breast cancer and other chronic diseases. Thank you guys very much.